UAlbany. And right now it's time for The Social Workers, a live radio talk show that deals with social work and related topics in the community. Today we have a very special program. We have three graduate students here from the University at Albany School of Social Welfare. Lissa Lotmore, welcome back, my co-host.
Hi, I'm glad to be here today because it's a really exciting topic for me because it's something that I'm not as familiar with. For those who don't know, social work has a lot of different populations you can work with, a lot of different specialties. So I focus more on education, and Eric, you're more of the mental health.
Yeah.
So I'm excited to hear a little bit more from these three students about what they can, what they're doing.
Yeah, and mental health is really one of the areas where social workers are most active today. The mental health field, a lot of people think of psychiatrists or psychologists as leading the field of mental health. Actually, the biggest professional workforce delivering mental health services in the U.S. today are social workers. So social work is really, in some ways, at the forefront of the mental health field and leading the way into the future in terms of how we deliver services to both adults and children who have mental health challenges. So that's just a way of sort of tying together social work and mental health, but we are very excited about the program. Let me introduce the students who we have here today. We have Amber Halverson, who is a second-year master's student in social welfare. We have Katie Merrill, who is also a second-year master's degree student in social welfare. And finally, we have Kevin O'Keefe, also a second-year student here in the School of Social Welfare. And all three of these students are part of a special internship program at the School of Social Welfare called the Albany Internships in Mental Health. And basically what that is it's a partnership-based program between the School of Social Welfare and the New York State Office of Mental Health. And the idea behind this program was to develop and improve the mental health workforce out there in the state. And the idea was really to sort of bolster the education and training of mental health social workers, specifically in the delivery of evidence-based practices. And we'll talk, in a few minutes about what that means. So Amber works and she'll tell you about this more, but she works at a family clinic here in Albany. Katie works for a state office dealing with mental health policy, and Kevin works in a clinic, also a PROS clinic, which is called Personalized Recovery Oriented Services. We'll talk more about what that means in a few minutes. But we've got some time here, and we're going to be talking about mental health, the current state of mental health in the U.S., how we think about mental health, how we talk about mental health, how we deliver help and interventions to people who have serious challenges with their mental health. So welcome to all three of you.
Thank you. Thank you. So let's get started with our questions, because we have a jam-packed show and lots of questions that I'm sure I'll come up with throughout the segment. So for what is evidence-based practice, how would you define it to our listeners, and even to me who's not as familiar with the principles in mental health as to what evidence-based practice is?
Evidence-based practice is a term that comes from the medical community, and it's basically a way of identifying interventions that have evidence base for them, that show that they are effective for dealing with whatever the issue is. So if you're in a doctor's office, you want your doctor to pick the intervention that's going to work for you, the medication that's going to work, or the therapy. And it's the same when you go to a social worker. You want to make sure that they're picking an intervention that's been proven to work with why you're there to see them.
So is there a certain amount of data behind it, research behind it, that is a criteria for having it be more evidence-based?
Yes. Things that are designated an evidence-based practice by the Substance Abuse and Mental Health Services Administration have clinical data that shows their effectiveness with the population. So there are clinical trials, preferably randomized clinical trials, that show the effectiveness.
For the interventions with mental health, for the evidence-based, is it more so for any age group? Is it focused on adults only? Is there some for children? Or
a lot of what we've been studying focuses on adults only, but there are evidence-based practices for all age groups, and it really goes a lot based on diagnosis.
Okay.
So how do people find out about these evidence-based practices? How do they start to be delivered and implemented in programs?
Well, a lot of it is things that we learn in school. We're introduced to a lot of different practices and given kind of an introduction to them. And then once you're in an agency, there should be a lot of training in that intervention that you're going to be using. So some of them are developed by different researchers, and they'll have certifications that you can get in different practices, and others you just have to do a lot of research and practice and work with your supervisor.
Thanks so much, Katie. And anyone else can feel free to jump in to answer some of these. But for evidence-based practices, is there a difference between the traditional types of practices that we see in mental health, or what is some of the, for those who don't have a full understanding of what would be an evidence-based intervention model versus what would be something that we think of more of a traditional model for an intervention for mental health?
So looking at traditional mental health interventions, a lot of that is going to be rooted in the belief systems of that time. So looking at the history of mental health treatment, you'll find that a lot of the negative beliefs about mental health were correlated with the treatments of people with mental illnesses. So now you're starting to see that the beliefs are changing so that there's less stigma. It does still exist, but it's not as strong. And so you see that we're trying to be trying to use scientific evidence to show that what we're doing is actually working, as opposed to just going off of what we believe works.
So let's talk about the stigma piece for a minute, because I think that's interesting. And, not everybody knows, we don't always think about stigma and what it means to, what it means to people who have a psychiatric disability or have a mental illness. How do you think stigmas get played out, and why do they have such a hold on our society still?
Part of the reason why I think they have such a hold is because, if a person, falls in line with what the stigma is, then it becomes stronger. So the more that we try and break the stigma, the less stronger it becomes, and it greatly impacts the clients that we work with. Some people, if they believe that they're being stigmatized, won't even come and seek services. So it's very important that we work to reduce stigma in mental health treatment.
And I think that also goes to when you're receiving, like how you said, when you're receiving treatment, so many times if we're injured with a physical injury, we have no problem going to the doctor. Everyone's sort of like, oh, you should go. But then when it's something that's mental, people usually say, keep it to yourself, or you can, just, toughen up. You can get through this on your own, keep moving forward. Whereas the push from others for someone to get treatment sometimes is less for the mental health piece. So with more awareness, in the news you see a lot more about mental health issues and people advocating, celebrities who might have some sort of mental health diagnosis are coming out more, saying, I want to advocate for this. Do you think that has a positive impact on having people feel more comfortable to go get the services they need because they feel not alone?
That's a really good question. I think it's kind of a two-sided thing. I think celebrities in our society are glamorized, so when they do come out as having a mental illness, it tends to be you kind of see them as, for the most part, recovered or at their worst stage. I think about so many celebrities over the years that have breakdowns, and you see that, and then a few years later, they're okay, they're performing again, but you don't really see the process from their low point to their high point. So I think in terms of celebrities, I think it's good, and it's good to get the conversation going, but there's a real process and hard work that has to go in between that I think celebrities in general just don't embody.
And that can also help interfere, I guess, with treatment, because people think, okay, I'm going to go in, it's going to be, then I'm going to come out fine. And I don't think they really captures a lot of the hard work, the ups and downs that can go through mental health treatment. Would you mind telling me a little bit more about what those ups and downs could be, or what's a treatment for the evidence-based? What does that look like?
Yeah, so one of the evidence-based paradigms or viewpoints, I would say, is a recovery model. So instead of being without symptoms, so without hearing voices, without having anxiety, it's more for focuses on managing those symptoms. So you're hearing voices, you're anxious. What are you going to do to limit those but not completely get rid of them? So some of the ups and downs is, today I'm not hearing voices, but tomorrow I might be. I'm thinking about substance abuse too. This week was really good for me. I got by this week with not drinking alcohol or using substances, but something happened and I relapsed. And in the recovery model, that's okay, and it's actually seen as a learning opportunity. A lot of solution focused is used in that kind of, what worked last time, what didn't work last time. If it works, as a basic rule, you keep doing it. But there are challenges depending on how you feel, other people's reactions to your relapse. And so it's, without being... There's that, it's not a day, you got to really take it day by day and sometimes hour by hour to just make sure that you're doing the best you can for your body and your symptoms.
That's actually really interesting, just how you describe that, because that's sort of not what people think of when they think of recovery. They think, oh, they had a relapse, it's failing, it's not working. Mm-hmm. This is, you're not strong enough. Sometimes, I say that in quotes because that's sometimes the feedback that people get when they do have a bad day, or a bad week and they're going through that tough time. But what's good about this model is it really seems like it's that strength-based. Okay, you can get back on, you can get back on track as to what your goals are. It's not all over yet, and you prepare them, it seems, for those ups and downs that come with recovery. Yeah,
it's I'm thinking of motivational interviewing too. When you say that, it's very it is seen as a learning opportunity to relapse and say, hey, you're right, you didn't do so well this week, but when we first started working together, you couldn't get past a week, and now you've had 3 weeks under your belt. So really trying to highlight the strengths as opposed to, okay, you got to go back into treatment, maybe a detox or whatever if we're talking about substance abuse, really affirming that they worked hard to get to that point and what worked in that time frame that was working should be modified to help continue that.
I'm really curious, I've obviously worked with you guys and studied and talked about and taught about recovery, but, maybe for an audience that has not been introduced to this notion of recovery, not so much from substance abuse, but in mental health, recovery from a serious mental illness, what does that actually look like for people? Can people recover and get better from mental illnesses?
Yeah, so I'm at a PROS program, which Eric said was a personalized recovery-oriented services, and so what it really focuses on our life goals and really saying, hey, like one of the first questions during the assessment intake is, what do you hope to achieve in life? And I've heard many different answers, from working to going back to school. Some people want to get a driver's license. So recovery is really defined by what the person wants out of life, and that's really individualized, but themes of working, living on their own are really two big ones.
And that seems like like I said, a strength-based approach. Is there any type of what are some of the challenges that you're seeing with this? And anyone can answer this. What are some challenges you see with this type of model?
I think one of the challenges I see is that a lot of the clients I see have been through the system for so long that they have in some ways lost hope. And we ask these person-focused, strengths-based perspective questions, and they don't know how to answer it. So it really becomes a collaborative process of really uncovering something that they can hold on to and keeping that in focus. And, like I said, a lot of these clients have been through the system for a long time. So one bad day, they really beat themselves up over it. So, we as clinicians, we may be trained in this recovery-focused thing, but perspective, but the clients themselves, I think that's really getting them to be inspired and hopeful is really a big challenge.
And I agree with what Kevin is saying, and and also with one of the challenges when you're talking about setting goals with clients is that when you ask a client, what are their goals, sometimes they don't know what their goals are. Sometimes they've never even been asked that question throughout their service. So for them to be asked what their goals are, oftentimes they're not sure. So it takes a lot of work between the clinician and the client to kind of define what their goals might be.
And that's something that, just thinking, how I said my background is in the education system, I can just imagine individuals who do have some type of mental health issue, they've probably developed it as when they were younger. And I can only imagine in the education system where maybe people are, teachers might not be as familiar with a certain diagnoses, or maybe the individual wasn't diagnosed at that age, and they're having, issues or behavior, things are happening. And instead of getting the strength-based approach and what are your goals, how can we work through this, I can imagine it was more of, discipline, getting sent out of class or something like that, getting told, you're not being successful, what's wrong with you. Whereas as they're getting older, now they're in this model where it is strength-based, where people are offering that support. You can get through this, that hope for them. It must be kind of a shock based on their previous experiences that they've had.
So just as a quick reminder here, I'm going to break in for 1 second, just say that once again, you're listening to WCDB Albany, you're listening to the social workers, and we have 3 graduate students from the School of Social Welfare who are all working in internships currently in the mental health field. And so Alyssa and I have been asking questions about their experience in mental health.
And I would like to sort of switch focus just a little bit, well, not too much, but I want to know about your current placement. You don't have to give the agency names, but I just want to know what some of the work is that you're doing through the Albany Internships and Mental Health Program. So anyone can start.
And maybe as you do that, if you could also tell us about the populations and problems that the folks you're working with face, that would be great.
Okay, so I work in a family program providing mental health services to families where one or more members have a mental illness. So I do a variety of things. I work with families one-on-one. I also provide group psychoeducation in the PROS program at my agency, as well as co-facilitating evening support groups where it's families coming together. It's called a multifamily group, and the families provide support to one another. So emphasis on the peer support. So some of the challenges that I face in that type of work is getting the families involved. Family involvement in mental health treatment is very important. It provides support and understanding for that individual. So when the families aren't able to function together or not understand one another, it can really impact the person's recovery and often can lead to more relapses if families aren't able to work together.
So what are some of the other challenges working with families? Do families have preconceived notions about what a mental illness is that you have to sort of untrain, if you will? Absolutely.
A lot of times the family will blame the individual and then see them as the problem. So what we have to do is kind of we do a lot of education about mental illness, about their symptoms, and trying to get the family to understand that the person may not be able to get a job because of their depression, not because that they're lazy. We do have to retrain the families in the way that they think about their loved one.
Okay. And how do they respond? How do the families, once they go through your program, do you see success, and what does that success look like for a family?
In my short time that I've been there, I have seen success with the families, and what it looks like is just the families seem calmer, they seem more relaxed, they have a better understanding of each other, and they can communicate with each other about their feelings, and so you just see that things just run a little bit more smoothly for them.
Great. Thanks, Amber.
You're welcome.
Katie, would you like to tell us about your internship?
Sure. My placement is at a state agency, and we look at how mental health services are delivered on the ground in the community. I'm in the Adult Community Services Division. So we deal with housing for adults with mental illness, PROS programs, which are what Kevin was talking about, outpatient clinics, health homes, which are our care management model, and our division is there to support these programs in developing and implementing their models. So we look at policy, funding, regulations, guidelines. Right now we're working on a request for proposals for moving people out of adult homes into more independent living situations through permanent supportive housing.
Can you tell the listeners a little bit about what an adult home is? I know this has been, in some ways, a controversial subject here in New York State.
Adult homes are, you might think of them as nursing homes because from the outside that's what they look like, but it's a place where people can live and they often have a roommate, but there's not that skilled nursing level of care. So it's a little bit more independent than a nursing home, but often it's hundreds of people with various chronic health and mental health issues just living in a congregate care setting, often quite segregated from the rest of their community and from their families. So what we're working on right now is moving people who want to move out of those homes into permanent supportive housing where they're in the community, reintegrated into their neighborhoods and with their families, and just able to achieve more independent living, and that really falls in line with the recovery model.
Yeah. One of the things that I hear you guys saying, sort of embedded in both of your comments so far, and Kevin, we'll get to you in just a minute, is that education, housing, community integration, some of these things are really, really important for folks that have psychiatric disabilities living in the community. And in some ways, I think of them as almost being more important than what we think of as traditional mental health interventions like therapy and counseling and medication. Can you talk, any of you, a little bit about the sort of distinction between a medical-based intervention that maybe is medication or a professionally-based intervention like therapy and counseling versus, some of these more pragmatic living things about housing, employment, education, et cetera?
Permanent supportive housing, supported employment, and now supported education are evidence-based practices, and they've been shown to be very effective with people with psychiatric disabilities because it's this return to normalcy. And it kind of embodies what the recovery movement is all about in terms of helping people live as independently as possible instead of encouraging that dependence on the system. So these supportive models allow people the dignity of risk. It lets them get a job or get an apartment without having to prove anything first, and oftentimes they're able to rise to the occasion and achieve that level of independence.
Great. That's a great explanation. Thanks, Katie. Or Kevin, would you like to tell us about your internship?
Sure. So I'm in a PROS program, and what it is it's actually a vehicle or platform for evidence-based practices. So it's a classes-based or group-based program. We call it classes because it's a lot more emphasis on psychoeducation rather than therapeutic groups. And there's a few components. So there's wellness self-management, which is doing activities such as drawing or writing or anything that helps manage your symptoms of whatever those are. And those primarily are the crux of the PROS program. And then we have intensive relapse prevention, which is helping the participants, which is what we call clients in a recovery-focused agency, helping them really identify their triggers and realize, hey, I'm not doing so well. Maybe I should do something for myself or reach out to someone. And then we do have a clinical component too, which is a psychiatrist on staff sees all the participants to manage their medication, but they're really, we really encourage the participants to advocate for themselves if the medication isn't working and, talk to the psychiatrist about any side effects or anything like that. So it's much different than a psychiatrist telling clients, okay, we're going to change this. They always have a say in the clinical treatment of their recovery.
Okay. Kevin, I just have a question about what you said. When we were talking about mental health recovery, I'm still a little bit confused. I know you said that it's a recovery-focused model, but then you also said managing symptoms. So when we think about recovering from mental illness, it just seems like, is it something that how do you recover from it? What does that mean?
And like I said earlier, it's really individualized too. So, someone's recovery could mean being asymptomatic. We really try and get it a little bit more goal focused. So, basically, like Katie was saying, it's living independently, it's going back to school, it's having a job, it's just having a meaningful life, I guess, if you want to put it at basic terms. And recovery just means that you're achieving that and you're working towards it. So I don't think it's necessarily an endpoint that we see, someone is recovered, which a lot of people can identify as being recovered, but really just as something that you strive towards every day. And, like I said, some days are better than others. So, but it's much more of a lifestyle, I would say, than a destination.
I liked how you said lifestyle, because that's what I was thinking in my head. I'm like, it seems like it's all the different avenues of life, how we were saying, education, housing, all those things come together to have that person have a new lifestyle that they might have not have been able to have before, because their mental illness sort of impeded them from having success or in those types of areas and arenas.
Yeah, exactly.
It also occurs to me, though, that it's a complex puzzle. It's a complex problem. So, in other words, that yes, it's about a lifestyle and sort of being able to live successfully in the community, but it seems like part of that puzzle is also the community's willingness to accept that person. So in other words, if there aren't housing options, if landlords discriminate against someone with a mental illness or a psychiatric disability, if neighborhoods are not willing to accept and integrate people with mental illness into the communities, or if, employers are not willing to take a risk on someone who has a mental illness, then, I'm wondering sort of what that tension is like for you guys as mental health providers, when the services and I'm conjecturing here a little bit, but maybe the services that you're setting up aren't always matched with the acceptance and welcoming atmosphere in the community at large.
So I would argue that's where social workers become definitely the tool or the agent of change, I would say, in the community. And I think that's where we differ from other professions, where, in my personal practice is I always keep in focus the social justice aspect of our profession and its values, and they have a right to everything that everyone else has, despite their mental illness. So I would argue that, if employers or landlords are not willing, definitely sitting down with them, meet them where they're at, landlords and other agencies, and say, what are you concerned about, and try and really be able to collaboratively come together and say, well, we can make this work, we just have to find the right, combination.
And I think that also goes back to some of the fears that society has. I mean, when you watch the news, if there's ever a crime, all of a sudden, it links back to some sort of mental illness that, the news is now portraying. And then it turns into less about the crime and more about this mental illness and how the public should be fearful. And I think it really... It's not an accurate portrayal, first off, of mental illness. I mean, most people probably with mental illness they're more of a harm probably to themselves, I'm assuming, than to other individuals in terms of the community. But how do we combat that? I mean, using the media, you coming on here today and informing, sort of using the public as that client, educating the masses about this topic. What else can we do to sort of take away some of those stereotypes that the media, the mainstream media, sometimes portrays on individuals with mental illness, and sort of take it back and say, no, that's not accurate. Here's what we're going to do to raise awareness. What are some things that we could do as social workers to get that accuracy out there?
I think that's where really talking about stigma comes in, because violence and mental illness are not highly correlated. A person with a psychiatric disability is no more likely to be violent than anyone else in society, but there is that unpredictable behavior, and I think that scares people, and it contributes to this idea that someone with a mental illness could hurt you. And I think that we just need to keep repeating the fact that studies and numbers show people with psychiatric disabilities are not any more violent than anyone else. And really, we just need to empower people with psychiatric disabilities to advocate for themselves and to show the rest of the community and society how valuable they are and what gifts they do have that they contribute to us every day. So actually that's a really good lead into an event that we're going to be hosting at UAlbany in 2 weeks. It's called Experts by Experience, and it's a panel discussion with adults with psychiatric disabilities where they're going to talk about their experience living with a psychiatric disability, what recovery means to them, and what professionals and community members should know about living with a psychiatric disability. So I'm glad you brought that up.
Great. It sounds like an exciting event. Why is it important for the public, or for even for the community here at the university, to hear the voices of these people?
Well, I think it's really important to fight stigma, like I was just saying, to make sure that these people are empowered to put a voice to what's going on with them. And I also think it's important for professionals to hear from that perspective as well, instead of in a one-on-one therapy context, to actually sit down and be educated by your client, by potential clients, by people who are facing the same thing that your clients are facing, and for the community to hear from people who are recovered or experiencing the journey towards recovery, and to hear what that's like. And I guess that's...
If anyone is interested who's listening to attend, is this open to the public? Is it only open to the university students?
It's absolutely open to the community. It will probably be a lot of students and faculty, but we hope to have community members there and people, professionals there, because we think that this really should have a broad audience, that everyone should be open to hearing these stories. So it is at 6 o'clock on Thursday, March 26th at the UAlbany downtown campus.
Great. So let's take a quick break, and then we'll come back with a few more questions and wrap things up. So you are again listening to the Social Workers on WCDB Albany, and we have in our studio, we have Amber Halverson, Katie Merrill, and Kevin O'Keefe, all graduate students studying mental health services and the intersection of social work and mental health in the University at Albany School of Social Welfare. We'll be right back with the social workers in just a moment. Welcome back to the Social Workers here on WCDB Albany. Once again, the Social Workers is a live radio talk show where we talk to people in the community and in the nation at large about social work and about topics related to social justice and social welfare in the community. Our special guests today are 3 graduate students from the University at Albany School of Social Welfare. We have Amber Halverson, Katie Merrill, and Kevin O'Keefe. So we're curious to hear a little bit about your personal stories and what got you into social work. Maybe if you could, we don't need your life story, but maybe if we could hear a little bit about, what pulled you into this profession, why social work, and then maybe why, once you got into social work, why mental health specifically?
So I became interested in social work while doing my undergrad. I did my undergrad in psychology and did an internship working with children with emotional disturbances. And I worked with a social worker there and was kind of between, do I want to do psychology, do I want to do social worker? And the social worker, the entire time was like, you're going to do social work, you're going to do social work. And, a couple months later, while I was applying for grad schools, I was like, yeah, I definitely want to do social work. And so that's kind of how I got there. I was just really interested in the things that he was doing for this program. So how I got into mental health was my first internship. I was placed at a PROAS program and really became passionate about that population. I found myself, wanting to fight that stigma and, talking with people that I knew who weren't involved in social work and telling them how it is when it comes to mental health, and it just kind of went from there.
And maybe, Amber, if you could tell us a little bit about where you see this heading for you. What are some of your future goals after, I know graduation for you is looming in May. Mm-hmm. So, have you had some thoughts about where you might want to go with this?
I definitely see myself pursuing mental health in the future. As far as where I'll be, it's hard to say. I'm very open to what the future may hold. So that's pretty much all I figured out at this point.
Great. Kevin, would you like to tell us a little bit about your journey into social work and what got you here?
Yeah, sure. So my mom's actually a social worker. So she did her MS. She actually went all the way through when I was in high school. So she got her BSW at MSW, and she just loved it so much. And so when I was thinking about continuing my education, she kind of pushed me into the profession, and I really have come to love it. Like I said earlier, the social justice piece, I really am finding, even though I'm clinical concentration, I really find that to be so important of, equality and equity. And mental health, I'm just fascinated with how it is such an internal problem. No, I don't even want to say problem, but it's just something, it just shows me so much about the human condition and how stress and anxiety and depression can, these in some ways are constructs of our society that we label them, pathologies, and yet it's, everyone gets anxious, everyone has some depression, some more severe than others, but it just fascinates me too to see that what people can overcome and the strengths that people have within themselves and how they can reach out for support. And I'm just continually fascinated and amazed by, recovery and that sort of viewpoint.
Well, your mom did really a good job of getting you into this profession,
yeah.
I should say.
It runs in the family, apparently.
Yeah.
And so what about the future for you?
Well, right now I'm looking at clinical positions because I do want to strengthen my clinical toolbox, but really I see myself going large scale, either training practitioners and social workers on evidence-based practices or really just self-care or anything, empowering clinicians to be the best self, or educating society. I have a deep interest in educating our youth on mental illness, telling them, really teaching them how to manage, wellness, self-management for themselves, because I think a lot of these adults with mental illness wouldn't have such challenges if we intervened at an earlier age, but that would definitely be on more of a policy and research-based platform.
Great, and maybe that's a good segue to Katie if we're going to talk about policy. I do have some follow-up questions that I'd like to ask you in a minute, Kevin, but I want to give Katie an opportunity to tell her story and why social work and why mental health.
So my parents worked in nonprofits my entire life, actually, since before I was born. And when I was 16, I started working in a group home for adults with developmental disabilities, many of whom also had mental health diagnoses. And I did that all through college, and then I worked in nonprofits for a few years after college. And it always struck me that whenever new regulations or memos came out from the state, I wondered who was writing them and whether they had ever worked in a group home or as a service coordinator. And after a few years of professional experience, I decided maybe it was time to go become one of those people at the state writing those memos. So I came to Albany to get my master's because I knew that I needed to learn more about systems and theory and why things happen the way they do and how decisions are made. So yeah, that's why I came back to grad school, and hopefully when I'm done, I will find a job at the state or doing something else equally exciting.
Great. Well, I have to say, it's, having worked with the three of you, I know you all personally, but having you on the radio, it's been really nice to hear some of your views on mental health articulated. Kevin, you mentioned a few things I wanted to come back to. The notion that mental illness or psychiatric disability, if you will, is something that in society, some people will say it's a social construction. It's something that we've we tend to label in medical terms. You use the word pathology.
Yeah.
We tend to pathologize people that have challenges with their own mental health. And I'm wondering, in fact, I just saw a news piece this morning about, and I think we've talked about it possibly before, about some alternative views on what mental health could look like if we didn't pathologize it. I know coming out of Europe and the UK, there's something called the Hearing Voices Network, for example, and there's starting to be some money here in the U.S. To look at what that might look like in the U.S., to examine that from a research perspective. And the Hearing Voices Network is essentially a way of allowing mental health service users or clients, people that have mental illness, to define their experiences differently. So in other words, instead of saying, that a person has schizophrenia, we say they hear voices. And that takes it away from being a medical illness that's linked to treatment, that's linked to social injustice, that's linked to, being hospitalized and put away from society, not getting opportunities that everyone else gets. But it simply says, there's someone that hears voices. It means, it's sort of like saying that someone is differently abled rather than disabled. Mm-hmm. And I wonder if you have some thoughts on that.
Yeah, I just think of our society at large and how we always try and fit into these categories and labels across our society, no matter what it is, whether it's, thinking of young teenagers as, self-proclaimed jocks or something. And it's just, I think as a society, we really like that because it helps us categorize people. Okay, I'm going to meet you. I have this preconceived notion of you. And if you don't fit that preconceived notion, it's very difficult for us as a society to individualize. So when you come to mental illness, you're right. I would rather work with someone who's hearing voices than someone who has schizophrenia. And I can't picture in my head what it would look like, unfortunately, because I think it's so far away. But I just think of being individualized across society, not even just in mental illness. I am a person. Mm-hmm. This is my personality. Some things may be similar to others, but for the most part, I'm individual. And I think building off of that, individuals working like that, identifying themselves as an individual can really change our society as a whole. Because when you and I work together and we, individuals work together, I think a lot can be done to change, as opposed to a group of this, a group of that. And if everyone has a collective investment in it, I think we can get much more powerful results.
It's an excellent response. Katie, I'm curious, because it was something Kevin just mentioned about individuals and sort of thinking of, you also mentioned earlier, Kevin, with recovery, about the need for recovery to be individually defined and that it's supposed to be individualized for each person. How, Katie, from your perspective, learning policy and the inner workings of state memos and the policy world, as you put it, what are some of the challenges in creating policy for groups and populations when we're talking about very individualized services? How do you create policy for individuals where recovery means something different from person A to B to C? It seems to me that there's a real challenge there. If we don't define mental health in the same way for each person, but each person defines it for themselves, then how do you create policy and then services that actually help people?
I think that's where the recovery model comes in, and at the state we've really embraced that model for providing mental health care. And so a lot of community agencies were founded in the 70s and 80s, and that was before the recovery model really set in. And some have really charged ahead and taken this model and embodied it, and others are still learning it and still coming along. And so at the state level, when we look at grants and new programs, we really emphasize that recovery is the model that we want provided. That's what we want the focus to be. So every service is driven by an individualized support plan or an individualized recovery plan, depending on the service. And we expect that those plans contain individualized goals. So the service might be permanent supportive housing, but the goals that are in the individualized support plan should be individualized to that person. Does that person need help with medication compliance or with cooking or with attending appointments? Or maybe they don't need any of that. Maybe they just need someone to check in once a month. Those things should be specified in an individualized support plan.
Great.
I just really enjoyed listening to what both of you had said, Kevin, about people fitting into the box, and then you more about the individualized plans, and it made me think about how all our systems kind of have that same, they need to fit into a box. Like going back to, like I said, to the education, if there's an issue with a student in a class, if they don't, they're not following the standardized test and on level where they should be according to the state, there's something with the child, there's something with that individual. They need a different setting. They need a different environment. Where it's instead of, okay, what can we do to make this environment work for this individual? So I think it goes across the board, and it helps us to really see about how all our systems are connected, because possibly that child in that school does have some sort of mental illness, or maybe not, but how can we work and make that, start this type of approach that you guys are doing now and translate it to different systems and see how we can make it more of a positive person in that environment type of approach.
I think that, it's an excellent point, Alyssa. I think one of the other things, and, we've certainly talked about it in classes, but the listeners may not have thought about it a lot, because I find that not everyone in the community thinks about this, but there's a long history here in the United States of mental health treatment in ways that really promoted social injustice, where people were housed in, what we used to call asylums and insane asylums and hospitals and institutional settings that really locked people away, kept them away from society, and really sort of embedded this notion that individuals that had a mental illness should be kept away from us, that we should be protected from them, they should be protected from society. And I think in some ways that history gets forgotten today because it's not happening quite as much as it used to. But, Katie, when you talked about the 70s and 80s, when the community programs were really starting and nonprofits, that it seems to me that long history, over 100 years, and well back into even colonial times, of really treating people in ways that were not healthy and not promoting their health, and in some ways were even killing people. And so that history, I think, do you think that still has an impact today? I'm just curious. Any of you?
I think that there's still an impulse towards institutionalization. Unfortunately, some people may have read a New York Times opinion piece recently, and it was also an opinion echoed in the Journal of the American Medical Association, that we should reinstitutionalize, that people with psychiatric disabilities and with intellectual disabilities shouldn't have these demands placed on them by the community, and that it would be cheaper and safer if we just put them back into an institution. So that's an idea that's being expressed in really world-renowned publications, and that's scary to me, that there are well-educated people who still have that opinion and impulse. So I think it's important to demonstrate the successes that people can have in the community, and to really push this recovery model and make sure that not only are professionals in the mental health field aware of it, but make sure that professionals across all fields are aware of it, and make sure that community members are aware of it, that we don't need to institutionalize or segregate people in order to stay safe or keep costs down, that there are more effective ways of managing psychiatric disabilities.
And more humane ways as well.
Absolutely.
Yeah.
And it's teaching those individuals in other professions those strategies too. I mean, just social workers aren't the only ones who are going to be working with someone who has a diagnosed mental illness. They're going to be in different areas, different arenas that you're going through as they go through different systems and different environments. So people in all fields really need to have some background as to what the proper interactions are. Know if they have any types of stigmas that they might be projecting on an individual. So more awareness, I think, in all professions regarding mental illness and how the best ways to interact and move forward are.
Right.
So you've been listening to the social workers here on WCDB Albany. We've had 3 very special guests in our studio live here today. We've had Amber Halverson, Katie Merrill and Kevin O'Keefe. All three of these folks are graduate students, second-year graduate students in the master's degree in social welfare program at the University of Albany's School of Social Welfare. And each of them have been talking about their experiences delivering evidence-based practice interventions in mental health. We'd like to officially thank you for coming on our show today. It's been really enlightening, and we hope that you as listeners have enjoyed hearing the experiences. I don't, could one of you, maybe Amber, could you tell us a little bit more, just remind us about the event that's coming up, when that is, what time, and what that will look like?
Yeah, so we have our Experts by Experience event coming up on March 26th at 6 p.m. We're going to have a good panel of people coming in to talk about their experiences in the mental health system. So just promoting awareness and helping to reduce that stigma.
And where will that be held?
The downtown campus at UAlbany.
Okay. And I think do you remember the room?
Milne 200.
Okay, so Milne 200, March 26th, Thursday, March 26th at 6 p.m. So you'll be able to hear the voices of people who have experienced mental health problems, have been in the mental health system, have really, I don't know, I'm curious, I know we're trying to wrap up, but I'm just curious about the title, Experts by Experience. Why those words, and what does that mean?
So basically it just means that people are the experts of their own lives, and we as social workers could get up there and talk about our views, but really they're the ones that have been the ones to truly experience this, so it's better to come from them. It means more coming from them.
Great.
And Eric, I do have one other announcement for an upcoming thing that we are actually doing. We're going to be holding a workshop on media savvy social work, which really is going to be about how to use the medium of radio as a way to serve the public as a client. So it's open to students, faculty, staff, and the community. It is worth CEUs for those who have their licensure. It will be on Tuesday, May 19th from 1 to 5 p.m. How to register is on our website. But it's really just a way to have individuals become more, social workers particularly, become more comfortable using the media. I think there was an article I saw last night that was talking about social workers. The title, it was something about a quote of social work terrorism. And of course I had to click on it to see what it was, but it was about a CPS issue, and it was caseworkers who weren't even social workers. So I think as social workers we have to use the media to give an accurate portrayal of what our professional is who we are, what we do, and also to reach the public and educate, as our three guests were talking about today, educate about issues that are social work related. We are experts, and this workshop will have individuals learn those skills on how to do that and to become more comfortable using the media as a way to get our message out there.
Great. Can you remind us the date and time?
It's Tuesday, May 19th from 1 to 5 p.m. In the morning, there will also be another CEU event. Dr. Miller will be discussing spirituality. So it will be a full day that hopefully people can attend and learn some new skills and have a training. And
just a quick reminder that, again, you've been listening to the social workers here in WCDB Albany. We have a web page. We have a YouTube channel. Maybe
Facebook
Alyssa.
page, Twitter. We have it all. So be sure, if you go on our main website, it's on the albany.edu/SSW. On that main page is a link to our show, The Social Workers, or you can just Google it, The Social Workers Radio Talk Show. And like I said, please like us on Facebook, follow us on Twitter, or subscribe to our YouTube channel. All these past shows are on those stations linked to that. So in case you missed it, you can always replay and also forward to anyone else who may want to hear.
Great. And we've got some exciting shows. We're not able to announce them just yet, but we've got some exciting shows coming up in the next few months. We're here on Thursdays. The first Thursday of every month, we're live at 9 a.m. And even in the future months, we may be here on other Thursdays as well.
Yeah,
so
we
please.
have a few special guests that we have so many guests, I think, that we might not be able to just cram it all in before the end of the semester. So we might be having some special edition shows. So
once again, thanks to Amber, Katie, and Kevin for telling us about your experiences in mental health and social work. And we will see you next month with the social workers.